All right, lots of scribble up behind me. Let's go to a case study here, definitely golf related. This is one of the most well-known golf teaching professionals in the world. And a lot of times when at least in my experience, especially recently, when we're seeing these golf issues, they don't always show up while you do your therapy, movement evaluation, local analysis, all the different things that you'd be doing as a therapist, chiro, whatever. You don't see that these problems abound. And even if you were to put them into a very high level specific golf swing analysis, a couple swings may not elicit their pain. Well, that can be really, really good and maybe not as good. It certainly is very, very good because it tells you a number of things. Number one, the severity, meaning if this was truly a dominant structural issue, in this case, left-sided lower back pain, it wouldn't go away when you just stop playing golf. That's just, if you had a nerve that was being compressed everywhere, all the way to this incredibly powerful central sensitization, it doesn't come and go to zero when you take away this physical provocation. So that's very useful. Whether it's positive or negative, we can decide. It can certainly become not so positive and maybe confounding because you can't find their pain. We could talk all we want about the realities of pain and what it is and what it isn't and biopsychosocial components. But when somebody comes for your help and they trust you and they can't reproduce their pain and or you can't pinpoint it or reproduce it with your testing approach, well, then it turns into an interesting discussion. And that's where we went here, where this is simply a loading issue, which then begs the next series of questions. Well, how come it doesn't become a loading issue for everybody? Well, that's just a myriad of other contributors. And let's just say with this particular patient, a lot of folks like to use the word robust. That's a combination of a lot of very desirable factors. This individual is not robust. And that's not an insult. That's just for me, it's actually the lowest hanging fruit. We did find, which we'll go through, we did find some components to our movement, our keen movement evaluation, and we were able to put a special exercise package together to address those particular weak links related to movement, related to mobility and stability. But this individual probably would do very, very well from gaining any kind of weight, would do well with gaining lean mass, would get better with specific threshold-based fitness components. All of these things would help. And it all, I think everything that we find makes sense. Now, everything from a local physical exam, you can't, nothing on palpation, nothing directly even on a quadrant test of the lumbar spine, nothing in our series of SI joint, Laslett, where you need 3 out of 5, nothing, just nothing revealing. Now, at the same time, I don't question the utility of those things. I just explained to you that we tried to use them. But this patient was not is not, I've known him quite a while, is not the most specific communicator in these physical analysis settings. So he's not making anything up. He's just not a very black and white communicator. What does this hurt? Does it not hurt? I think he communicates, and I think you'll see this in a lot of people that you work with. Well, they can deal with it. It's not that bad. We really need to get to it. Does it get worse, or or does it feel fine? And it's just a little bit challenging. So none of our local analysis was able to yield anything that would give us a quick fix. And also remember, a lot of that local analysis is based on pain provocation. And we don't have any pain right now, only right at this point in the evaluation process, under the assumption that is only because he hasn't played golf, because his back hurts when he golfs. All right. So let's go to the SFMA, and you're going to see the faces. And as I've talked about many times in the past, I will try very, very hard to never use specific language. If I say something is DN, dysfunctional non-painful, you are now in debt. I have to tell you what that means. So I'm just going to put because I'm usually whiteboarding while I'm evaluating. While we all know what DN means and we have a high value for what that means, for the patient, I'm just going to put a sad face. Meaning, okay, this is something that's not ideal, and you could even question if that's an even useful approach, but it's what I'm doing. Okay, so we're always going to do a happy face, a nonplussed face where the line, and then a sad face, and then we just start to unravel this. And that way, the patient is aware of that to some degree that I saw something that requires more review. It doesn't mean they're good or bad, or always saying there's not a contest. I don't care if you can touch your toes. I just want to see what you do, and I'm going to draw some faces to help me categorize the information. If you have a better way, put it down in the comments. Good chance I'm still going to use the faces, but I would be curious if you have a better way. Okay, so now let's start with forward bending, and we have a nonplussed face. It didn't look smooth. Knee bend. I think we did have a uniform spinal angle. He was able to touch his toes, but this did not look smooth or athletic. But no pain, which is a very, very good sign, because if somebody was raging in some of these potential structures, posteriorly, nerve root, compression of the nerve, something would bark when you forward bend. But because it looks so wonky, I have every reason to think that this will become a part of our special exercise approach, unless there's a redundancy for what else we decide, which was multi-segmental extension. Now, the first thing that we found was if we put arms down and look at multi-segmental extension, significant improvement of excursion and a little bit more ideal uniform spinal angle. So already we know that the thoracic extension component and or neck and shoulders are a part of this. Okay, so before we move on to what we continue to learn about multi-segmental extension, multi-segmental rotation, again, it didn't stick out like a sore thumb like extension did, but just doesn't look very, very athletic. Single leg stance, 25 seconds, no problem. Deep squat, unable to get down. We did test dorsiflexion and we confirmed. So even though we have a question mark, I wrote that at the time, and I didn't go back and change it. Okay, shoulders in both directions looked fine, but he did have a history of labrum, and again, that feeds into how this individual communicates. It's like, man, like if you don't have pain, just pick the heaviest weight you can that's pain-free, and let's go for 30 to 100 reps, rehab for meatheads. So, I don't care about our special tests when it comes to this history of things. If you don't have pain right now, but you have pain when you're training, you're just picking the wrong entry point. And we did get into that communication a little bit later. Cervical flexion, very good. Extension, no good, which would then take us back to what we saw up front, and rotation to both sides, a little bit wonky. So extension is where we would go, and obviously we should expect a degree of redundancy in extension and rotation. But keep in mind, We've done all of these movements and we have not had any report of pain or increased pain. We had a cascade of opening joint symptoms, closing joint symptoms, some things that moved in the way we think they should move, others not so much. But we don't really have much right now. We don't have a lot going on. But we did know that multi-segmental extension with arms overhead just was really south. Not a lot of check marks that we need there, which is the ASIS moving in front of the toes. We're looking for scapula behind the heels. We're looking for hands behind the scapula, and we're looking for uniform spinal curve. So we didn't have that cascade, okay? So now when we looked at unloaded, remember our concepts here is always going to be change positions, eliminate joints, change stabilization demands in active versus passive. So we're going to look at a prone press up, prone extension, and we still don't have a uniform spinal curve, particularly a very, very flattened thoracic component there. So again, we're simply confirming something. Now, when you go through your Keene movement evaluation and you start to see consistency as you change positions, change stabilization demand, eliminate joints in active versus passive, and you start to see the same things regardless of those components that you modulate, you're probably going to look at some form of a mobility issue. That means the joints can't get there. We don't know why. It can be the joint, could be soft tissue, or it could be neurolocked, okay? Lumbar unlocked, spinal rotation, lumbar unlocked. So we're putting the arms in a plank position. We're bringing them as close as possible so we can standardize. One hand in the lower back, not obligatory, but preferred. Whereas people that have shoulder pain, because their spine doesn't rotate, we'll just put the hand, up here and get the rotation. But it would likely will change the 135 degrees that you're looking for from the angle that is created from the shoulder across the shoulder girdle that is rotating away from that stable side, okay? We were able to produce pain on both sides. So we're getting a sad face there. Now, as we move south, I would test anyway hip internal rotation and significant limitation of left hip internal rotation versus right, as well as when not stabilized, hip internal rotation on the left elicited his left pain. Same thing with hip extension. So I went off the reservation a little bit and looked at rotation and extension, and we should understand that the capsular pattern of hip extension and hip internal rotation probably the same. So right now we're seeing, again, what typically fits into this pattern of when you stop the activity, you don't have any issues. But when we find mobility limitations, which we can change our mind from a treatment approach, but right now we're simply going to say that the left hip doesn't move as much or as freely as the right hip. But then when you rotate heavily on that and take that side, you have momentum, you have gravity, you have all of these different functions that takes the joint forces further than what they can attenuate because the mobility is not there. So you take a mobility issue and then create a stability issue. Now, I have no idea if this individual's technical prowess of his swing is affected, because it doesn't have to be the same. Like you could have all these problems and pain and still be hitting every fairway 300 yards downfield. This can all be the case. It's never a guarantee that when you see these things, it always comes to play. But certainly we believe that working somewhere on that left hip is going to be our solution. Whether we go anterior to improve hip extension, whether we go into glute medius, glute minimus, these are some common areas that you at least start with, and then see what we can get. Now, that's actually what we did, and I'm not going to suggest that pain was abolished. I don't think that's the case. But again, I'm not confident in my ability to translate what this patient was saying. Maybe, dare I say, a little almost defensive in what was painful and what was not, which I don't really understand because I'm just trying to help. But I don't think it abolished. I do think we're on the right boat by needling the left hip, needling L5-S1, and just some requisite soft tissue work to reproduce. Did we have pain in lumbar unlocked spinal rotation? Okay, so now looking at what we would do from an exercise standpoint to start with. And also giving this individual a good understanding. We're going to work on spinal rotation, and depending on what commercial model you use, that's where the value of the SFMA is compared to evaluation models that only take you to that commercial approach, because here I think we need to improve spinal rotation as a result. That was our test. That was painful. So we need to put that somewhere in the plan. So if you follow certain models, they'll call it negative or positive torsion. So if I twist away is for right rotation, I'm going right rotation, negative torsion. But if I were to twist this way, is positive torsion. Positive torsion is the same as a Bretzel 2.0. It's also the same as some form of oblique sitting. So lots of different ways. So I would always try to leave it open-ended, because I don't care which commercial model the exercises come from. I just think we need to improve the things on this list. That's the most important piece. I think we would look at the ZOAS, and we would look at, just to start, I don't recall that we did the Thomas test just based on how we zipped through this evaluation. I think I missed that, but we would go after the ZOAS and then build a chain out of that. Moving forward there into multi-segmental extension, we would also certainly look at the ankles, which while we did confirm a dorsiflexion limitation, we did not confirm if there was any other types of contributors other than tibial rotation where he was fine. Do we need to get into the navicular? Do we need to get into the cuneiforms? Do we need to get into any of the relative soft tissue around the subtalar joint? All of those things can make difficult ankle mobility situations look real good. We are absolutely going to work on Eldoa pattern for hip internal rotation, 100%. And then we will just start with T6, 7, 7, 8, 8, 9. Whether they are valuable for rotation or extension, I think the answer is both. And particularly T6, 7, which is somewhat of the middle of the thoracic spine. And then as a result of this, call it lower crossed crashing through impact and follow through, we're going to work on sagittal stabilization, intra-abdominal pressure in that 3.5 month position, where when your legs are up, 90-degree hips, 90-degree knees, we start that stacked position in the pelvis. The spine is relatively flatter. I'm suggesting that this individual's spine on the left gets into extension. He's moving far more in extension in the lumbar spine than anywhere else, and it's probably more a result of the left hip creating this emergency break through the middle of the swing. So we would be here for 3.5 months, sagittal stabilization, and I just wrote dead bug just because that's what most people seem to attach to, but you can do many different patterns out of that position, including no pattern. Just work on breathing, work on that exhalation position and being able to breathe and create the proper stereotype of the circumferential pressurization of the viscera and the abdominal area. So some of the things it's always cool to see, like when the SFMA, you just follow the rules. But the thing that's really important here is I don't care what exercises or treatment that we use. That is completely up to anybody. And many of you have heard me say many times that I don't care if you spread peanut butter on this, just beat these tests. The hip had a big component to it. I think the ankles have, hey, look, thoracic, hips, ankles. It kind of comes out in the wash, which would probably be attributed to somewhere else if you heard that first from a different model. Evaluate for the purposes of complete ignorance to how you fix this issue. Just create language and create a cascade of, if you handed this plan to someone else, you don't care what they do, but in 2, 4, 6, 39 weeks later, you test it the exact same way and something is improved. That's really what we're after here. In this case, I do think the golf component is, and that's always going to be the case when there's a physical activity that is being performed with a degree of inefficiency. If you just stop the activity, then your pain pattern goes away. So it becomes a little bit more of a detective work to try to establish causation, and you got to be very, very careful when we use the word causation. This is just our plan A. All I can do is say that these are things that I think are part of the issue. Let's try and change them with special exercises. Let's get fit, which is a major, major component here. Obviously, in other types of Instagram videos, we've talked about the training piece, the nutrition piece, the sleep piece. These are all crucial components. Here was just the movement piece. And probably in this case, I think the fitness component, like if this evaluation never happened, and this individual just trained and ate and slept like a professional athlete, then I think we would probably get past this. But again, that's just my thoughts on causation. So hopefully this all makes sense. And we have not found in some time, since I've been doing some different videos, but if you do happen to come across, maybe it's even a golfer like this in the Crichton section of Mobile, Alabama, you look up in that tree, you see a leprechaun, say, yeah,